Hi guys, we're going to talk about chapter 46, and this is really going to focus on that nursing care of the child with an alteration in cellular regulation, hematological, or neoplastic disorders. So we're going to focus in on some of our cancers, some of our bone disorders, and some of those cellular regulation disorders. So let's just get started here. So functions of the hematological system, you know that we all know that we have different blood cells. So erythrocytes are our red blood cells. They are responsible for transporting nutrients and oxygen to the body and waste away. If we have low RBC levels or issues making these cells, then what should we be most concerned about? And if we've talked about transportation of nutrients and oxygen, our biggest concern would be oxygenation. If we don't have enough of those cells and they're not, or our body's not making enough of those cells. Thrombocytes, our platelets, are responsible for clotting. Too much can cause overclotting, too little can cause underclotting. And then leukocytes are our white blood cells you should be pretty familiar with, and those are the ones that help us fight infection. Erythropoiesis is the production of our RBCs. Hemolysis is the destruction. So just a couple of definitions here for you. Pediatric patients with hypoxia will stimulate the reproduction of RBCs to help decrease the low oxygenation that's being experienced. One of the major hematological issues children face is anemia. Anemia is the most common hematological disorder of childhood. There is a decrease of our RBCs and or our hemoglobin. And we know that those are the oxygen carrying cells for our body. And if that decreases, then it decreases our oxygenation to our tissues. As the decrease in RBC and hemoglobin decrease, then production decreases as well. Nutritional deficiencies that can cause anemia include iron deficiency, folic acid deficiency, and pernicious deficiency, or anemia, sorry. And we are going to talk about iron deficiency specifically for this chapter. So iron deficiency anemia occurs when the body does not have enough iron to produce that hemoglobin. So there's usually an inadequate supply of dietary iron. This is generally preventative. Therapeutic management. So what are we going to do with these kiddos? We're going to give them those iron supplements. Ferrous sulfate is the preferred form because it absorbs the best. We can do blood transfusions in very, very severe cases. As far as nursing assessment, we're going to start with that history. We can ask about risk factors, we can evaluate the diet history, and then we're going to observe for any fatigue or lethargy, remembering that those red blood cells are not getting, we don't have enough of them, right? So oxygenation is low, meaning it's going to make us very tired. It's going to make us feel very lethargic. We also want to inspect our skin, conjunctiva, the oral mucosa, the palms and soles for any pallor. We can also note any spooning of the nails, right, from our chronic hypoxia. And we talked about that last week. We're going to auscultate and evaluate for any tachycardia. Tachycardia is a sign of prolonged anemia, as well as we're going to look for splenomegaly. So we'll want to auscultate and palpate for those symptoms. As far as recommended dosage for elemental iron, we're going to, for prophylaxis, you can see it's 1 to 2 mg per kg per day. Mild to moderate, we're going to bump that to 3 milligrams per kilo, and we're going to usually divide that in a couple of doses. And then if we have severe iron deficiency, 4 to 6 milligrams per kilo per day, divided again in those 3 divided doses. As far as educating our families for the recommended dose and when to dose, we really want to recommend that they give that medication with some type of citrus juice because that really helps absorption. We also want to make sure they're giving it between meals. As far as food rich in iron, you can see all of those listed there: red meats, tuna, eggs, tofu, grains, beans, green leafy vegetables, iron fortified breakfast. Right, when we're doing our education, these are also things that we can really talk about. Once that child has done some dietary changes, we've started them on some iron supplements, we're going to draw those iron levels pretty routinely for several weeks. Treatment usually takes about 3 months to see improvement, but we want to make sure we're seeing improvement, so we are going to draw those pretty frequently for several weeks. All right, so toxin exposure is the next one we're going to talk about, and that includes lead poisoning. So the peak of incident is usually about 1 to 5 years of age. When lead is seen in the red blood cells, it creates small red blood cells, which leads to anemia because we're not creating those nice, big, juicy red blood cells anymore because the lead is not allowing that. Sources can include paint in the homes, especially if the homes were built before 1978. I'm sure you guys have all been made aware of that, right? All of the newer homes are made with non-lead based paint, right? Dust from windowsills, walls, plaster in the older homes, right? Because that paint has chipped away. 1 to 5 year olds might be eating it, right? And that's increasing the lead levels. Soil where cars are parked can lead to increased lead levels. Glazed pottery, lead pipes. If a parent works at a manufacturing job, they can get lead on their paint, on their clothing. So we always recommend taking that as a health history, right? Maybe changing their clothes before they come in and see their kiddos. Folk remedies such as arzagon, and then old painted toys or furniture. These are all just sources where our kiddos can pick up lead. Some common symptoms of acute lead poisoning can include anorexia, nausea, vomiting, abdominal pain, and constipation. If our kiddos get undiagnosed lead poisoning, it can lead to some very serious complications. Lower levels of lead poisoning can include behavioral problems, learning difficulties. Higher levels can be encephalopathy, seizures, or even brain damage. I will tell you, one of the worst cases I've seen of lead poisoning was actually in 2 siblings. They were eating the dirt. Guess what had been parked on the dirt previously, right? An old rusty car for lots and lots of months. So they're eating this dirt. They presented with all the abdominal issues: nausea, vomiting, anorexia, discomfort, right? Normal lead levels are typically less than 5 mcgs per deciliter. These siblings' lead levels were 52 and 63, right? Really super high lead levels. So they were in danger of those higher level complications. The unfortunate part of this wasn't the first incident that they'd have of these high lead levels. So social work got involved. Hopefully they're doing well, they're thriving. Treatment for these high lead levels or for any elevated lead levels is the chelation therapy. They're going to start that intravenously. It can be given orally. In the case that I saw, we started it IV, right? We needed to get that lead out of their system quickly. That chelating agent removes the lead in the soft tissues and bones. Lead exits through that renal system. So how do we prevent this? Education, early screening is really key to prevention, and then helping parents understand where lead can be found. So aplastic anemia is the next type of anemia that I'm just going to briefly here. When we talk about nursing assessment, we're going to get a really good history. This is usually an exposure to myelosuppressive medication or radiation therapy. So this is why a lot of times we don't send our kiddos that are less than 2 years of age to get x-rays. If we can diagnose them with pneumonia without a chest x-ray, we're going to do that. We don't want that exposure. We're going to get a detailed family, environmental, infectious disease history. We're going to ask about epistaxis, which is our nose bleedings, gingival oozing, increased bleeding with any menstruation, if they're having that as teenage females, any headache, fatigue. Physical examination could include ecchymosis, petechiae or purpura, if they got oral ulcerations, tachycardia, or tachypnea. Right, those are just signs of prolonged anemia. So if they have those, then this has been going on for a while. And then the last one we're going to look at is hemolytic anemias, and that's our sickle cell and thalassemia, and we're really just going to focus on sickle cell for this chapter. So what is sickle cell anemia? This is a genetic disorder that causes red blood cells to sickle or change in shape. Sickled cells are stiff, they are sharp instead of soft and round. These cells can cause problems all over the body. Sickled cells block flow into the blood vessels, which deprive our tissues of oxygen. This deprivation of oxygen can cause what? Tissue damage and pain. So what can we do to help these patients? We can oxygenate them, right? If we oxygenate them, hopefully it stops that sickling process. We can look at infection and crisis prevention. We can control their pain, and we can give them lots and lots of fluids. So this is the most common anemia. It is autosomal recessive disorder. It occurs primarily in our African American population. About 1 in 12 African Americans are carriers, and about 375 infants are born in the United States with sickle cell. It can also occur in our Mediterranean, Middle Eastern, and Indian descents as well. So instead of hemoglobin AA, which is that healthy older infant hemoglobin, sickle patients have hemoglobin SS. The lifespan usually is much shorter, so many children may have to go under a splenectomy that can lead to severe compromised immunity, just creating a shorter lifespan. I will tell you that the lifespan, I think, has increased over the years because we are more knowledgeable about it, but they still have a shorter lifespan. There is a decrease in oxygenation, stress or infection, and again, those red blood cells can become elongated and sickle in shape. So if we give oxygen, that's going to help facilitate those cells moving through the bloodstream and preventing further sickling. A sickling crisis can lead to pain due to tissue hypoxia and necrosis. This pain can be seen usually in the abdomen, long bones, joints, really anywhere in the body if they're having that crisis. So clumping can occur. We'll talk about that in a second. Tachycardia, tachypnea is just going to create more sickling of those cells. So again, what are we going to do for these patients? We're going to oxygenate them, right, to push those cells through and hopefully create new, healthier cells. We're going to try to prevent that sickling crisis and infection. Most of these patients are going to be on some type of anaphylactic antibiotic because infection creates more sickling, and then making sure they have appropriate immunization coverage, especially if they've got to get their spleen removed. So we're going to perform a very thorough assessment. Sickling, hypoxia, and tissue ischemia affect most areas of the body. We're going to make sure we measure their temperature to evaluate for any infection. This isn't something we're going to measure. We're not going to educate our families to measure it daily. right? We're only going to measure it if we feel like something might be going on. If they're complaining of more pain, maybe we're taking their temperature, because we know infection can precipitate some of that sickling. We want to determine a mental status baseline. That's that neurological assessment. That's going to help us recognize if any stroke symptoms occur quicker. Dactylitis, you can see there is a swelling of the hands. A lot of times they just have like those big sausage fingers. So you can see all of the different effects that sickle cell can have on our bodies. Hemoglobin, labs and diagnostic studies that we're going to think about to assess for sickle cell. Hemoglobin electrophoresis is really the only accurate test to help us test for hemoglobin SS and to diagnose sickle cell. There are common labs after sickle cell has been diagnosed that we will talk about, like reticulocytes count, that's usually greatly elevated, a peripheral blood smear, which just shows the presence of those sickling cells. Platelet count is usually increased. Erythrocyte sedimentation rate, or ESR, that inflammatory marker is usually elevated. They also have elevated bilirubin, which is that lysing or breaking, and that bilirubin is just escaping. So nursing management, hydration, oxygenation, and pain relief. If our patient is in a pain crisis, we're going to go through the A, B, C, D, E, F, and we're going to assess using a pain scale. We're going to be consistent with that pain scale that we used. We're going to believe what the patient is reporting. If there's any complications, we have to investigate those. We have to investigate those complications or the causes of our pain. Treat with opioids or narcotics as scheduled meds. When that pain is under control, then we can maybe switch to our PRN, less invasive medications. Maybe our NSAIDs, maybe we can use some coping mechanisms. We can help with distraction. We can keep the environment quiet, dark, and private. And then we're going to hydrate with lots and lots of fluids. So if our patient's in a pain crisis, remember this A, B, C, D, E, and F. Sickle cell crisis, let's look at that. So you can see the clumping that occurs. You can see that picture that shows our red blood cells are sickled, like that moon shape, and now they're clumping, which is causing, usually patients that are dehydrated have an increased concern for sickle cell crisis. So keeping these patients hydrated will decrease that cell clumping. When cell clumping occurs, that means that vaso-occlusive obstruction is causing significant pain and organ damage is now a big concern. Signs and symptoms of cell clumping could be fever, tissue engorgement, swelling of the joints. They are going to have lots of pain. We've talked about that. Abdominal, long bone. They'll have that hand-foot syndrome, which is that dactylitis, which are those sausage fingers. And they are going to see a lot of joint pain. If they have complications, what can we think about doing? Antibiotic therapy, oxygenation, removing that spleen. But remembering if we remove that spleen, it decreases their immunity. And then down at the bottom, there is that mnemonic HOP. If the hospital, they need to hop to it, right? Hydration, oxygenation, and pain relief are our main treatments of choice for sickle cell. So as a recap, increased fluid intake, double maintenance requirement, right? We know what maintenance requirement is with our calculation. We're going to double that maintenance requirement. We're going to administer oxygen, right? Because that's going to help the sickled cells get out. It's going to help refurbish some of the, make some healthier cells, and it's going to prevent necrosis from our tissues from happening. So we do need to educate our families. If they have any febrile illness, they need to seek attention right away. Make sure they're vaccinating as scheduled they're staying hydrated, they're avoiding high stress situations. If they have more pain, they need to go see the provider immediately. Any signs of infection or signs of stroke need to get help quickly. Remembering our infectious signs are fever, pale, listless, abdominal pain, swollen joints. Stroke could be a headache, numbness, visual changes. So lots and lots of education for these families. There is a preventative medication of choice that these patients will be on regularly or daily, and that is hydroxyurea. So hydroxyurea is that medication they're going to take daily. It's going to increase the levels of fetal hemoglobin, which is our AA. That's the one we want. Our red blood cells live longer and they sickle less. It can cause reversible neutropenia. But the biggest problem with this is they have to take it every day. So compliance can be an issue. All right, let's move into some clotting disorders. So clotting typically occurs after an injury. The blood clotting system relies on certain factors in the blood and platelets to perform this adequately. Major bleeding disorders can affect children, and these include idiopathic thrombocytopenia purpura. ITP is probably what you've also heard it as. This is an immune response after a viral type of an illness that produces antiplatelet antibodies. Schonlein purpura, HSP, develops also after a viral or bacterial infection. Disseminated intravascular coagulation, or DIC. These patients are usually critically ill and they have an overactive coagulation. And then factor deficiencies, and this is what we're going to focus on, and we're going to really look at that hemophilia. Hemophilia A is factor 8. Von Willebrand disease, just understand that that's a factor deficiency. Hemophilia B is Christmas D, or factor 9 deficiency, and hemophilia C is factor 11 deficiency. So let's look at hemophilias. We're going to, look at idiopathic thrombocytopenia purpura. So this is, again, petechiae and purpura. Those are just definitions that you should just be familiar with. This is usually an immune response, again, following a viral infection that produces antiplatelet antibodies. The antiplatelet antibodies lead to development of petechiae, purpura, and excessive bruising. So petechiae are those pinpoint hemorrhages occurring on the body that do not blanch to pressure. So you can see on this little picture here, all of those tiny little purple spots, if you would push on them, they wouldn't blanch. That's petechiae. Purpura is our larger purplish areas of hemorrhage in which blood collects under the tissue. And I don't know that I would probably say any of these are purpura. Maybe the one on the forehead that's a little bit larger, or the one on the cheek there might be considered purpura, but these are usually pretty significantly large purplish areas. All right, so now we're going to talk about hemophilia. Historically, the prognosis for hemophilia was that most kiddos died at age 5. Now, mild to moderate hemophilia patients can live near normal lives. So this is a group of hereditary bleeding disorders that results from deficiencies. It is also X-linked recessive trait, just so you know. So hemophilia, there are 2 types. Hemophilia A, which is classic hemophilia. This is the most common type and accounts for about 80% of all cases. It is an X-linked recessive. About 1 in 5,000 males are affected. Females are typically carriers. It is a factor 8 deficiency, and the degree of bleeding depends on the amount of clotting factor. Hemophilia B, or otherwise known as Christmas disease. So it's also known as Christmas disease because the person that diagnosed, discovered it, whatever you want to say, his last name was Christmas. So that's why it's called Christmas disease. It accounts for about 15% of hemophilia cases, and it is factor 9 deficiency. So what does hemophilia look like? Clinical manifestations can really range from mild to moderate to severe. Hemoarthrosis is the most common seen symptom, and that is that bleeding into the joint spaces, which can really cause disabling joint pain. Extensive bleeding may be seen after minor surgical procedures, so boys that get circumcised, kiddos that have tooth extractions, right? These are minor surgical procedures with extensive bleeding, and that can be the first time that they may see this disease process. A lot of times we don't see symptoms until after the kiddos reach about 6 months of age. And if you think about it, at 6 months of age, they become more mobile, right? They're rolling, they're starting to crawl, they're starting to stand and walk, which leads to more injuries from bumps and falls. And that's a lot of times when we start seeing this disorder. So with hemophilia, there is a deficiency in one of the coagulation factors in the blood. Hemophilia A is factor 8. So we can give factor 8 and they can live very normal, healthy lives. This can be done in the home setting. And we have to remember that this is not hemorrhage. They are bleeding at a normal rate. They just have prolonged or continuous bleeding, which can lower their hemoglobin because that bleeding is longer. So we can identify the bleeding, hold pressure, and administer that factor 8. We also want to probably try to avoid activities with high potential for injury. So these are probably the patients that aren't going out and playing football, right? That's a high injury sport. If they're going to bleed for a prolonged period of time, it's not worth that injury. There is no cure. Good nutrition can be very helpful. Good dental hygiene can be very helpful. We can do IV administration of that clotting factor. We do have to be concerned of prolonged nosebleeds. They bruise easily. They can have warm, painful, swollen joints, right? That's the biggest or classical symptom for them. They could have gothy ground emesis, right? Bleeding, cola-colored urine, bleeding, tarry stools would indicate more bleeding. So interventions that we can think about for hemophilia, we're going to do close supervision and have a safe environment. If they have to have dental procedures, it just needs to be in a controlled situation. Make sure we're only shaving our patients with an electric razor. If we use just a regular razor and we nick them, we're going to have lots of bleeding that occurs. Superficial bleeding, we're going to apply that pressure for at least 15 minutes. And then hopefully use some ice to help vasoconstrict it. If they have significant bleeding, we may need to transfuse for that factor replacement. All right, now we're going to move into childhood cancers. These do differ from adult cancers. Embryonic tissue that mutate rapidly. So childhood cancers grow in the connective tissues that are formed during embryonic growth, while adult cancers form in the skin or tissue cells that line internal organs. So that's the biggest difference, is it's embryonic versus epithelial. Adult cancers can also be influenced by environmental factors where childhood cancers are not. So how do we treat childhood cancers? We're going to do chemotherapy and radiation. Occasionally a stem cell transplant can be used. Chemo works to destroy the cancer cells. Unfortunately, these medications also disrupt normal cells, which can cause adverse effects that may include immunosuppression, increased incidence of infection, nausea, vomiting. We can also use radiation to kill cancer cells. Hemopoietic stem cell transplantation, also known as bone marrow transplant, can also be used. It's used in high doses of chemo and radiation to the point of destroying that child's blood marrow. So we're going to really just use that in very advanced cancers. So some of the most common childhood cancers, In order of frequency are leukemia, that's the one we're going to see most currently. We'll see some CNS tumors, lymphomas, neuroblastomas, rhabdomyosarcoma, Wilms tumor, bone tumors, and retinoblastoma. So lots and lots of different types of cancers in our childhood. So here again are the common types. We'll start with leukemia. The ALL, or acute lymphoblastic leukemia, is more common than AML. This is the most common form of childhood cancer. A third of all childhood cancers are leukemia, usually ages 2 to 10. Acute leukemias are rapid progressive diseases that affect those immature cells. Chronic leukemias progress more slowly, permitting those maturation of cells so that they do retain some of that normal function. Acute lymphoblastic leukemia, or ALL, 85% of all cases occur in children we've talked about from 2 to 10. The prognosis is based on their white blood cell count. Leukemia is an unrestricted proliferation of immature white blood cells in the blood-forming tissues of the body. The liver and spleen are the most severely affected organs. The higher the white blood cell, the worse the prognosis. Some of the leukemic cells demonstrate high metabolic needs, depriving the body of nutrients, which again is going to cause fatigue, weight loss, growth arrest, and then some of our muscle wasting. So when we think about therapeutic management, it's going to focus on giving chemotherapy to eradicate some of those cells. Depending on the number of cells, depending on how the chemo works, bone marrow transplant may also have to happen. As far as nursing assessment, some of the common signs and symptoms that we may see are fever because of recurrent infection, because of immature white blood cells. We may see unusual bleeding or bruising because of that decreased platelet count, pallor because of decreased RBCs, bone pain. They're pushing those cells out of the bone marrow as quickly as possible and pushing on that bone, which causes significant pain. Vomiting and anorexia, unsteady gait. We're going to need to determine history of varicella vaccine. If our patients get chickenpox, that is a very overwhelming disease process that could lead to infection. As nurses, we need to empower our patients and families with knowledge of the disease and treatment so they can have a more positive outlook and improved quality of life. So this slide just gives you kind of a recap of symptoms of leukemia. We know they're going to be anemic because of the decreased hemoglobin. They'll be neutropenic, which puts them at high risk for infection. And they'll be thrombocytopenia, which just increases their bleeding. So if we can think of leukemias as numerous immature white blood cells like ants in an ant colony, right? They just keep developing these immature white blood cells because that's all the body knows. So that's just a recap. All right, lymphomas is the next one that we will talk about. We can talk about Hodgkin's disease, which is more prevalent in those that are older adolescents, 15 to 19 years of age. Non-Hodgkin's are more prevalent in our children less than 14 years of age. Hodgkin's is a neoplastic disease originating in the lymphoid system. It metastasizes to the spleen, the liver, bone marrow, lungs, and other tissues. There is staging that occurs 1 through 4, and then those stages are also classified as A, which is asymptomatic, and B, which means they have the presence of symptoms. Some of the signs and symptoms that we may see are weight loss, fever, night sweats, fatigue. When you palpate, you will feel enlarged lymph nodes that may feel very rubbery and clustered. That's a very classic symptom of our Hodgkin's disease. Non-Hodgkin's lymphoma is about 60% of our pediatric lymphomas are non-Hodgkin's. It's a quick progressing disease. Again, deep lymph node and pain, but they're deep enough that we're not going to be able to palpate very well. They usually are very responsive to treatment, symptomatic for only a few days before being diagnosed. Brain tumors is the next one we'll talk about. This is the most common solid tumor, second most common type of cancer. So type of tumor and location of tumor in the brain determines the extent to which it can be safely resected. Complications are hydrocephalus, increased ICP, brainstem herniation. Patients with hydrocephalus from the tumor or removal of the tumor may require that VP shunt that we talked about a couple weeks ago. As far as therapeutic management, we have to identify the type of tumor at the time of surgery. Radiation may be used, but it's usually only given to those greater than 2 years of age. Common assessment, nausea, vomiting, headache, unsteady gait, blurred vision, seizures. I don't know if I've talked to you guys about my little guy that I had in my PCP office. Right, he got up, he went to walk, unsteady gait. That's when we determined he had a brain tumor. Inspection and observation is going to include neuro checks. We're looking for strabismus or nystagmus, maybe those sunset eyes, right, that comes with our increased ICP, altered coordination of gait, altered sensations. As far as nursing management, mannitol we're going to use to decrease cerebral edema, frequent vital sign checks, pupillary checks, as well as level of consciousness checks. We're going to monitor for signs of increased ICP, preoperatively shave the portion of the head that's going to go under surgery. Post-op, we've talked about mannitol, vital signs, and neuro checks. They may need to be restrained upon awakening. They can be very combative or aggressive when they start gaining their consciousness back, so we may have to restrain them. We're going to definitely lay our patient on the unaffected side with the bed flat, and we're not going to raise the foot of the bed, right? Just picture that, right? All of the blood goes to the head. That's probably not the best thing for you to do. Patient should be laid flat on the unaffected side. Some bone and soft tissue tumors. These are less common than other cancers. Osteosarcoma. Common site is in the long bones. Usually we have to surgically remove that. Chemotherapy after surgery. Radical amputation is that amputation of the entire extremity or the entire affected bone versus limb salvation, which is just trying to remove the affected portion of the bone and replacing it with a cadaver bone. Ewing sarcoma is also listed there. It's a highly malignant bone tumor, usually more rare. A fourth have metastasis before diagnosis. We want to discourage any activity or play on that bone because of increased fracture. I think the biggest thing with this is our teen concerns, right? Body image changes, self-esteem. They're going to complain of dull bone pain, bones that don't reproduce cells very quickly, so it's slow growing. So you may see a limp, you may see some gait issues with these. So what are some health history related to hematological functioning? We can think about birth and maternal history. Were they a low birth weight? Did they have gestational diabetes maternally? Was vitamin K given after birth? Right? These are just questions that we could consider when we're getting our health history. Recent illnesses related to blood cell distributions. What are their sleep-wake patterns? What are their bowel patterns? Family history, typical diet, or risk for lead exposure. So as we're looking at all of these, you should be thinking about if they have risk for lead exposure, then what are they more apt to have, right? And it's that lead poisoning. So all of these just health histories can help us determine hematological function. Some common labs and diagnostics that we've talked a little bit about, but we're going to focus on with this one is blood type and cross match, right? It prepares our patients that may need transfusions based on the blood loss from any trauma. Clotting studies, those are PT, PTT levels, clotting factors, things like that. Coag factor concentration helps us diagnose hemophilia or DIC. CBC with differential helps us break down that white blood cell count. That might be helpful in telling us exactly what might be going on. Hemoglobin electrophoresis evaluates normal versus abnormal hemoglobin, right? That's that AA versus SS in our sickle cells. Iron and lead levels. Iron evaluates iron metabolism to help with anemia diagnosis. Lead measures that lead level, which helps us possibly lead to lead poisoning. The retic count measures any immature red blood cells. High levels could indicate bleeding or anemia issues if low levels. And then serum ferritin measures the ferritin, which is that major iron protein in the blood. It's the most sensitive test for iron deficiency anemias. So main components of our CBC, this should be very much review for you. RBC is the actual number of counted RBCs. Hemoglobin and hematocrit are the proteins in our red blood cells. RBC indices measure the cell diameter. White blood cell count is the actual count of the number of white blood cells in the volume. With the differential, it can break down the cells by neutrophils, eosinophils, basophils. You can see a shift to left that may be concerning, or that may be occurring, and that would just be a concern for a worsening infection. Platelet count, number of platelets, and then mean platelet volume, again, a measurement of the size of those platelets. So this is a hemogram that's been taken from your book. White blood cell, RBCs, hemoglobin, hematocrit, platelets are important here. Remember, platelets don't really vary much with age. You'll look at these pretty consistently, so I would just make sure that you're familiar with these. As far as test purposes, I'm not going to break this down super tight. Just know that platelets don't change much. You're going to be looking at these a lot as you get into your nursing career, so just be aware of them. Priority assessment, children with diagnosis of hematological issues, anemia, bleeding disorders, cancers are going to have pretty similar symptoms. They're going to see skin color changes, pallor, bruising, flushing. Those are some of the first signs of a problem. Mental status changes, lethargy, decreased hemoglobin, which causes decreased oxygen delivered to the brain. That's probably going to be a later sign. A thorough assessment approach, meaning we're inspecting, we're observing overall appearance and energy level of the child. We're documenting all of those findings from our head to toe assessment. We're auscultating breath sounds, heart sounds, bowel sounds. We're percussing the abdomen, noting any presence of dullness upon palpation. We're looking at all the signs of decreased RBCs and platelets, increased or decreased WBCs. Again, assessing hypoxia, fatigue, and pallor, especially with our kids with anemia. So we've done a really thorough assessment, and then we know that analysis is the next step in our nursing process. So what are we analyzing for? Fatigue, pain, impaired physical mobility, ineffective health maintenance, anxiety, and effective health family coping potentially. Some of the common medical treatments that you'll be using for all of these patient populations based on whatever disorder they may have, right? Supplemental oxygen, hypoxia is related to sickle cell crisis or severe anemia, blood product transfusion. Will be seen with RBC, WBC, and platelet disorders. Splenectomy filters out bad blood cells and becomes enlarged, so that may need to be removed. Again, you'll see that in our sickle cell kiddos. Hemopoietic stem cell transplant is an option for treating our hematologic disorders as well as some of our cancers. IV hydration, remember hydration is huge with sickle cells. Lumbar puncture is getting some of that CSF to determine if any metastasis has occurred. Radiation treatment looks for solid tumors, leukemia, lymphoma. Other treatments, chemotherapy, helps kill cancer cells at least at 1 point, if not at 2 during that cell cycle. It's usually the first line of treatment and then stem cell transplant. We do need to just remember that chemo cannot differentiate between cancer cell and healthy cell. So we will see healthy cells, unfortunately, die. So we have healthy cell issues as well. Radiation pinpoints the cancer cells, and then hemopoietic bone marrow transplant just really means they have no immune system. So we're going to use that with very advanced or aggressive disease processes. Common medications, we've talked a little bit about some of these. Iron supplements, folic acid with our iron deficiencies. I'm going to misspell this one, deferoxamine, the second word's easier. That's that iron toxicity for chronically infused children. Factor replacement, 8 or 9 are our replacement deficiency or clotting factors for hemophilia. Antibiotics hopefully kill any bacteria. Hydroxyurea stimulates hemoglobin, better hemoglobin in our sickle cell kiddos. IVIG is usually used with idiopathic thrombocytopenia. We have chemotherapeutic agents and biotherapy, all common medications with any of our disorders we've talked about. Lots and lots of support for these families and patients. Think about your psychosocial impact, right? Cancer is significant stress for children and families. They're going to need lots and lots of support and education. So there's lots of things out there that we can send those kids to as well. Camps, give them just some really great opportunities. So trying to increase that psychosocial because it's going to be very, very impacted with some of these diagnoses. And that concludes chapter 46. I know it's lengthy and I apologize for that. There's a lot of information for this chapter. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.